Hello everyone, I'm Raghavi, Resource Associate with DRITHI at IPH. Thank you for joining us today for the inaugural episode of Conversations on CDOH, a webinar series that aims to bring together scholars, practitioners, and thought leaders from India and beyond to deliberate on the concepts of commercial determinants of health. Before we begin, a few housekeeping points. Throughout the webinar, the participants are requested to be on mute. We request all of the participants to name themselves clearly on Zoom. If possible, with the details of your organizations, this enhances our interaction, especially in an online medium. Today's webinar will be recorded and all of you will be sent a link in the coming weeks. We invite your comments and questions, so please use the chat box during the webinar. All your concerns will be addressed in the chat box. And if you have any questions for any speakers, just type it in there and we'll take it up. Time permitting, we'll take everything up during the Q&A at the end of the session. All the participants remaining throughout the webinar will receive a certificate of participation to their registered email IDs. Without further ado, I will hand it over to my colleague, Dr. Srinidhi Srikumar, who is a postdoctoral fellow with DRITHI at IPH, to introduce the Institute of Public Health and our work around CDOH. Over to you, Srinidhi.
Thank you, Raghavi. Once again, a warm welcome to our esteemed panelists and the participants who have taken out time to be part of this inaugural Conversations on CDOH series. We've been looking forward to this for quite some time now at the Institute, and it's really an honor to have you all here as part of this inaugural webinar series. However, before we jump right into the actual conversations, I'd probably like to take some time to sort of brief you on the context in which our work on commercial determinants of health has emerged at the Institute, and also probably introduce you to the Institute of Public Health itself. So we are an academic non-profit entity that was established in 2005. We are an organization that has been recognized by the Ministry of Science and Technology. And this is also our 20th anniversary year in 2025. And over the last 2 decades, much of our research focus has been to strengthen health systems using health policy and systems research as a tool, and to also generate learnings from them to engage in public policy engagements as well. In addition to these efforts, a core work within the Institute has also been on tobacco research, work on the political economy of tobacco, and work on how tobacco and their interactions within policy and their influence on health. Lately we've also widened our scope to also include other psychoactive substances like alcohol, cannabis, and opium. And we also have a history of working in research and activities that sort of work on the domain of health in all policies. So a natural evolution in that regard has been the shaping up of a Center for Commercial Determinants of Health at the Institute. So the center actually is trying to build on the learnings and the experience that we have generated over the years through tobacco research and health impact assessment research to sort of try and widen our scope of research to a wider ambit of commercial determinants of health itself. So at the center, we are trying to sort of try and do research at a theoretical level to look at various concepts on commercial determinants and try and indigenize them to Indian context, and to also try and apply commercial determinants as a lens to look at various health policies, various health issues that are prevalent in India. We also recognize that this is a field that's relatively new within the larger domain of public health. So we are also trying to sort of facilitate capacity building and skill building around commercial determinants of health in the country, and maybe in a future period we to try and generate a community of practice around commercial determinants of health in the country as well as in the South Asia region. And we are also trying to partner and collaborate with other academic institutes and public health organizations to fast track the adoption of commercial determinants of health as a lens to look at various health issues in the country. And finally, we also hope to generate learnings from these activities to assist within public policy making, as well as use our learnings to engage with commercial entities themselves to help them try and mitigate any downstream negative health impact they might have through their commercial activities in the country. So this is the larger ambit of commercial determinants of health, Center for Commercial Determinants of Health. And coming to the project DRITHI, which is one of the key projects that is currently housed in the Center for Commercial Determinants of Health. DRITHI is the acronym for Developing Research and Action Capacity in India to Counter Harm Industries. So this is a DBT Wellcome Trust India Alliance funded project led by Dr. Upendra Bhojani, who's a senior fellow and former director at the institute. So the core objectives within Project DRITHI is one, to examine various public policies and the history of policies on various psychoactive substances like tobacco, alcohol, opium, and cannabis, and the specific role these harm industries might have played in shaping these policies in the country over the many decades. And second, to also critically look at the various concepts and frameworks around commercial determinants of health, and to see their contextual fit within realities of India, and thereby to promote its integration into health and policy research in the region. A core activity, like I said, as part of the center as well as in the DRITHI project, is to promote the commercial determinants of health research in the region, as well as to achieve a community of practice around commercial determinants of health. As part of this, Dr. Upendra Bhojani and his team has been visiting various academic institutes across India to organize seminars, lectures, workshops, as well as mentor scholars who are interested to take up CDOH as a lens for their research inquiries. Over the last 1 year, we have reached out to 300 scholars across through 10 outreach sessions across 8 states in the country. And the hope is to actually widen our reach to reach as many institutes as possible to try and achieve a community of practice that are actively adopting CDOH as their area of work. A second component within the DRITHI project is to critically look at the commercial determinants frameworks and concepts. While we know that CDOH is a relatively newer concept that has emerged over the last couple of decades, much of this research, much of this framing has been evolved from an OECD context. While we don't see this as necessarily good or bad, the key theme that we anticipate is that, given the fact that India is a very diverse setting and we have a very unique historical trajectory in terms of the development of various commercial entities and the practices they adopt, we feel that it is important to critically look at these frameworks and to also look at the discourses that might have informed these frameworks to try and see if we can optimize these frameworks to context within India. And we also are also trying to add value to the larger discourse of commercial determinants globally by generating learnings from various Indian schools of thoughts that have already talked about the role of commerce and how they might impact health within the country. So these are the larger works that we are doing as part of DRITHI, and this current conversation is an extension of this work on looking critically at these frameworks on commercial determinants of health. Through these conversations, we are basically trying to achieve or initiate discussions and deliberations among experts and scholars within India and beyond India to try and deliberate possible avenues to sort of optimize larger frameworks on commercial determinants and their implementation within Indian context. In the future, we are also hoping to host more webinars in this direction, involving more experts from India and abroad. And we all hope that this is something that you find valuable in terms of your own research. And without further ado, I'd like to hand it over to Raghavi, who would take the proceedings further. Thanks, Raghavi.
Thank you, Srinidhi. Let us move on to the session now, and I'm pleased to introduce the moderator for today, Dr. Upendra Bhojani. Dr. Bhojani holds a master's and PhD in public health. About 2 decades of his research and teaching experience spans chronic conditions, tobacco control, health policy and systems research, political economy of health, and health inequity. He served as the director at the Institute of Public Health Bengaluru from 2019 to 2023. He is currently a senior fellow at the Institute and holds the DBT Wellcome Trust India Alliance Senior Fellowship. Over to you, Upen.
Thank you very much, Raghavi. It's indeed a privilege, to engage with very eminent scholars of our times to deliberate on commercial determinants of health. For those of you who are new to the concepts of commercial determinants of health, we are basically going to talk about business and health intersection. So while it is not new, the fact that businesses significantly shape people's health and health inequities has been known for a while. I think what's probably new and exciting is that probably in last 15-20 years, there has been an emerging body of work which has looked at theorizing these intersections, in what all different ways businesses affect people's health and health inequities. And I think it's that part which becomes more interesting. So what we are going to do today is that we have 4 scholars joining us as panelists, and I will try to engage them on discussions. The core theme we want to explore today is that how people come from different kinds of journeys, different entry points, different disciplines, working in different contexts, and end up doing work which people might label today as commercial determinants of health. So that's what I would like to do in the rest of the webinar. Those of you who have questions or comments for panelists, please type them out in the chat box. If possible, mention to whom you are asking this in specific, and then I should bring those up towards the end of our conversation. Great. So without further ado, let me start with Professor Fran Baum. Thank you, Fran, from joining. I guess you're joining from Adelaide, from Australia. Yes, wonderful. So I think for our audience, I will have a brief introduction. So Professor Fran Baum currently is a program director at the Stratton Health Equity, which is hosted at the University of Adelaide, where she is leading research on social and economic determinants of health inequity. Fran is also a past president of the Public Health Association of Australia and is currently a co-chair of the Global Steering Council of the People's Health Movement. So thank you, Fran, for joining. And I think you have a long-standing work across sectors, but I can see that throughout your work, you have emphasized on some of the key concepts, especially health equity, social determinants of health, and what we call healthy public policy. And I think you also done health impact assessments. And more importantly, I think I saw that you have developed what you call corporate health impact assessment tool before we started having the discourse on commercial determinants of health. So I think we will be very interested in knowing how you got onto these thematics and what kind of work you drew on, and any of thoughts you have on how commercial determinants of health are being taught today, because I see you are also one of the co-author of a very important Lancet special series on commercial determinants of health. You also want to flag any specific aspects of CDOH that you think we should particularly give more focus to. So over to you, Fran. Fran, you are on a mute.
Thanks, Upendra. Thanks for the invitation. It's lovely to be here. I am indeed in Adelaide, which is on the traditional lands of the Kaurna people, who of course suffered from colonisation that could be seen as a commercial determinant of health, I think. So we'll note that. So Upendra's asked me to reflect on my journey from sort of social determinants to focusing more on commercial determinants. And I guess I've always been interested in researching the social determinants of health. My original discipline was history, And you only have to look at history to see how important social and commercial determinants are to health. One of the things you didn't mention, Upendra, was that I was also a commissioner on the WHO Commission on the Social Determinants of Health. And I think in lots of ways, in that commission, we really looked at all the different social determinants. We looked at housing, urban planning, food systems, health services, a whole range of social determinants. But we also had that section at the beginning of the report on power and resources. And much of that really talked to commercial determinants. But if you just think about each of those things, if you think about urban planning and housing, well, immediately, and I'm sure it happens in India as much as in Australia or other countries, commercial developers are vital to, can we have healthy urban planning? Can we have healthy housing? If you think about food, well, I thought about if we look at any food systems, the commercial determinants are vital. We only have to look at the whole baby food history of infant milk formula and how there's been such commercial pressure to market that, or the IP on traditional seeds, which I know has been a huge issue in India. Or at the moment in our country, there's very big opposition to healthy labeling on food from big food industry. So another example. If we look at gambling, we know that the gambling industry benefits from problem gamblers. They make a lot of money from that. And I don't know if it's the case in India, but in Australia, so many young people are now hooked on internet gambling when they're watching sport or something like that, sport bets. In terms of global health governance, you just see how the big private foundations have affected global health in a huge way in terms of setting agendas, in moving health systems away from comprehensive primary health care. That's been really important. So I guess the work on the Commission on the Social Determinants of Health really highlighted that power, money and resources, but also my work, and I'm sure Ravi will talk about this, we've both been very active in the People's Health Movement. And our analysis in the People's Health Movement, if you look back to our People's Charter, which was written in 2000, it doesn't use the term social determinants of health, but it talks about an unfair global economic environment that isn't healthy. So one of the things we pointed out in the first Lancet series was that we have a global economic system that really is geared in favor of economic interests. So that's in terms of who holds the power. There's been a real shift in the last 40 years from state power to commercial power. If you look at the norms of the global economic system, it really prioritizes private over public. And of course, there's a whole lot of externalities that commercial companies make to the state. So, if you take big food, the unhealthy kind of non-communicable diseases that result from people shifting their diet from healthy food to unhealthy food gets externalized to health systems. All around the world, in both high, low and middle income countries, we're dealing with non-communicable diseases now as becoming the major burden. So I think that's really important. And if you look at the way that commercial power is exerted, it's through a whole range of strategies of lobbying governments, of giving donations to political parties, of just changing the sort of discourse so it really emphasizes private. And of course, we've got the perfect example now in the US with the power of Elon Musk, a completely unelected figure who is actually destroying much of their federal government and US aid, which of course is going to have is already having a massive impact on countries throughout the world. So there's no doubt about that allegiance. I think the other thing at the moment that my research group is looking at has been the power of the big consulting companies in driving those norms. So by that, I mean, the big three are McKinsey, the Boston Consulting Group and Bain & Co. And the big four consulting companies, Deloitte, Ernst Young, Pricewaterhouse and KPMG. And I don't know if people have seen, there's a fantastic book by Mariana Mazzucato called The Big Con that I'm sure many of you have read. But what we've done is dig down and say, well, how does that kind of work of those big consulting companies actually affect health equity? So we've published one paper on that. And one of the big ways they do that is by really de-skilling public sectors, public services, because governments outsource so much money to these consulting companies that that really leads to a de-skilling of public services and takes away a lot of resources from the public good. And I guess we've also found that a lot of the work they do, according to public servants, isn't that useful. Now, they come in, they don't know, they give a report. It might be the same report they've delivered in the Netherlands a year ago, and then it turns up in Adelaide in a very similar way, but it doesn't really deal with the specifics of the people. And I guess then, I think one of the questions you've already read out was, well, how does this affect people? Well, we think this whole sort of corporate domination of society, we've just published an article in the Journal of Epidemiology and Community Health, setting out a research agenda on alienation, using the Marxist concept of alienation and saying, well, how does that happen? And Marx obviously said it happened through production. So there you look at these sort of unhealthy ways in which people are employed, the conditions that they're subjected to, what's called gig work. And you can show that that leads to a whole lot of alienation. But we're also arguing that there's a whole lot of alienation from consumption, that people's interactions with a lot of particularly big corporations is quite alienating to them. There's a whole lot of practices that lead to alienation that we're arguing create poor mental health. That might be hanging on a phone, trying to get a service when you've only got chatbots on the other end or something like that. Or it might be whole communities being ripped off by large corporations. And, one example I think is very famous is in Kerala, the question of Coca-Cola and water. But there's mining companies around the world in terms of indigenous peoples who are extraordinarily alienated from their land, been alienated from their cultures because of the practices of large mining companies. So we think this notion of alienation is a really important theoretical concept to link commercial determinants of health to poor health outcomes. So, if you look at poor employment practices, we know that can be linked to non-communicable diseases and including mental health, but it can also be linked to the rate of occupational injury. And of course, in public health, our big argument is, well, we want to ensure that social determinants are promoting health as much as possible. And one of the big ways by doing that is through policy and regulation. And yet, whatever time public health people propose regulation, whether it's in relation to food or tobacco or to injury prevention in the workplace, the commercial people will say, oh, no, we can't do that. It's too expensive. It won't work. Actually, there's not really an issue here. And then there's lots of evidence that science is then manipulated to show a different outcome. So there is this real tension between the public good mission of public health and the way we want to improve the way that social determinants work and commercial determinants which are really working against that. So I think I've probably had my 8 minutes, Upendra, and that just gives you a bit of an indication of where my thinking's going and what research we're currently working on. So I'll stop there and pass back to you.
Wonderful. Thank you very much, Fran, for painting that very vivid picture of commercial determinants and how you got to work on many of those. I really liked your reference to colonialism while starting your talk. And I hope to pick up some of these themes. You also referred to the Commission on Social Determinants of Health, a very important milestone and work within public health. And also thank you for highlighting your work on these consulting companies. I'm doing my degree in history now, and then I get to read Karl Marx in detail. And it's good to know you expanding on the use of alienation as a concept to study commercial determinants of health. So thank you. We'll come back to you, Fran. Maybe I'll now move to Professor Rama Baru. Thank you for joining today. Just to introduce briefly, for those who are not knowing her already, Professor Rama Baru has been a former professor at the Center for Social Medicine and Community Health at the Jawaharlal Nehru University, one of the very prominent public institution in India. She is also an honorary fellow at the Institute of Chinese Study in Delhi. And for long term, she has engaged into various kind of advisory roles, including to the Department of Health Research, to the ICMR, the Indian Council of Medical Research. I think when I started my public health research career at IPH Bengaluru in early 2000s, there was limited scholarship on private sector in health. And I think a lot of those things came from you, Professor Baru. And I think you continue to expand that gaze on privatization of provision of healthcare services, but also of medical education, and what were the impacts of those on access to healthcare in India, on population level health outcomes, but also importantly health inequities. I also have read that you have framed epidemics as a marker of socioeconomic inequalities. Very interesting. And I think I was going through some of your papers where you have also interrogated how the very model of economic production impact people's health and health inequities. So if I'm not forgetting, I think your basic training was indeed in basic sciences. I think you started with, you were trained in botany and zoology, and then you moved to social work and health sciences to really understand public health as a very complex area which requires a very interdisciplinary perspective. So I think it would be nice to also hear from you. Like Fran came from history, a much more social science thing, while you, I think, went towards it after your own initial experience around health issues. So how is it that you see, through your work, how do you see the way today commercial determinants of health are being discussed, and what do you feel are the important aspects that those of us who are interested in CDOH work must not miss our sight from? So over to you.
Thank you very, very much. Thank you, IPH, Dr. Bhojani, and this very illustrious panel here. Thank you, Fran, for setting the scene. Yes, I started with a basic science degree, zoology, botany, and chemistry. Toyed with the idea of going into medicine, but certain events and exposures in my life moved me to the discipline of social work, where I trained as a medical and psychiatric social worker and actually worked in community health settings, largely with disabled persons, especially children with disabilities. And in the process, when we were working with children in poor communities, we realized the gaps in the preventive, promotive, curative, and rehabilitative aspects in terms of access to care, and also the kind of pressures and difficulties families faced as they negotiated the required expertise, in quotes, to treat their children. And that's when actually I realized the limits of the public sector and saw how there were so many private players in terms of the services required for dealing with disability. And I think that kind of stayed in the back of my mind. And I also realized that health services is just one of the inputs for improving health status of populations, and also to address the distress that illness, disabilities can cause families and communities. And therefore, I felt that this philosophy, the larger liberal philosophy of the social work profession, which was about helping individuals help themselves. So there was a lot of onus on individual responsibility, which of course is the dominant refrain even in the medical and public health training, kind of moved me away from looking at individual suffering, which of course was very important, but I got interested in looking at what are the structural determinants of individual suffering. And that took me to the road of inequalities and, the really moving into the area of social sciences, looking at the intersection between what Fran mentioned about the histories of societies, especially post-colonial societies, global inequalities, and how they then get transferred even after independence in many of these post-colonial societies, and how certain basic inequalities were not questioned, and that clearly had an impact on one, access to health services, but more importantly, access to opportunities, access to mobility, and questions around that have health consequences. That's what took me to the Jawaharlal Nehru University, where I did my MPhil and PhD. And that was the only department of its kind, and it sort of gave me the scope to sort of interrogate and further my interest in looking at this larger relationship between society and health. Interestingly, when we were taught public health in JNU, our focus was public services and looking at health as a public good, and also to interrogate the lacunae and the gaps that exist within the public system and how it produces health inequalities in access, but also looking at the questions of access to food, water supply, sanitation, the basic needs approach, and looking at how the state's inadequacy, in a sense, created many, many gaps, and that led to inequities. And what we discuss today as out-of-pocket expenditure is not just on health services or medical care, but it is in a range of other determinants which have been articulated in the present time. I think when we were looking at the health system, because our focus was primarily the public sector, we kind of did not even acknowledge the fact that there was a very large, very differentiated private sector, very heterogeneous in its nature. And there were, some references, and I remember the early work of Sehat on the private sector, which was around the same time that I was looking at it, but I was looking at it at the level of a state. I was looking at Andhra Pradesh, and I was looking at why is there variation across districts? What is Telangana today and what's coastal Andhra? Looking at the growth of the for-profit sector, and also looking at the growth of non-profit sector. So it was very interesting that there was a certain logic in the way markets grew, and the logic of even locating what we call as NGOs was related to the level of social and infrastructural development. So you found that there was this inequality in the distribution of public, private, and non-profit. So much more skewed towards developed areas and less in the less developed districts. So that was really my early MPhil work. And that moved me on to understand the private sector. But also in my MPhil, I looked at what is the social basis of commercialization. And that was, I think, important because we realized that where is this capital coming from? And here it was very interesting to look at how there was agrarian surpluses going into the growth of the later on private medical education, but early on, nursing homes and smaller hospitals, not your corporates. There were no corporates in the 70s, 80s. 80s, of course, is the later 80s when the corporate hospital first comes up. But what was very interesting was that it was the rich peasant class that was really diversifying their capital, along with the traditional elites. That is the Baniya Brahmin kind of a complex that, and largely in urban areas. So it was an urban phenomena, but it had also sort of percolated to semi-urban and second-tier and third-tier towns. And in fact, Gail Omvett had observed this in her work on Maharashtra in passing, where she says the rich peasant invests in professional education as a source of mobility, which was kind of reflected in what I saw in the coastal Andhra. So you would have an investment of a male, and that too, there was a gender dimension. You would invest for your son's education to become a doctor, one would become a lawyer, one would take care of the farm. So, it was a very interesting phenomenon. And the third element that came out in the Andhra Pradesh story, as it did later on in Maharashtra, was the movement of this rich peasant class to the United States and UK, that what we call as the non-resident Indian phenomena. And they, in fact, come back in the 80s and 90s to invest in your corporate hospitals. And so I was interested in the social basis of commercialization. Although I quantified what the numbers involved were, for me, this was the more exciting part. So if you like what, as Fran mentioned, you saw early growth of capitalism, agrarian capitalism, being used to spawn industry, and you also saw its spill over to the health sector. But largely it began with the medical sector, then it went into medical education, it went into various other pharmaceutical industry is a classic example of the kind of investments that were made. And as you know, the private sector, domestic private sector in the Indian context has been large, and one of the hubs was Hyderabad. So with that interest, I went back to do my PhD, and I said, I want to interrogate the private sector. And Dr. Banerjee, who was then the chairperson, said to me, what is the problem? Why do you want to look at the private sector? You will take away from what is important about the public sector. And that's when I said, no, there is a mixed economy here, and the private sector's growth is impacting the public sector. And over time, we are going to see its unfolding and its weakening in the way in which I think Fran was also alluding to, this alienation of the public sector workers, the very change in the idea of what is public. And this got really exemplified when we went in for the subtle adjustment program and the health sector reforms. And so, it was just not about shift in policy in terms of these structures, but there was something fundamentally that was happening to the way the public institutions started thinking and how they started behaving. And so, the contractualization of workforce, for example, these were all recommendations of the health sector reform process. And at this point, and a little later, Maureen McIntosh and Meriko Vosulu had a very large unrisked funded project of which I was a part, where they were looking at and really problematized this idea of commercialization. Because I think so far we were looking at the private sector for what it was, but what they tried to bring in through the concept of commercialization was to say that the role of markets, and the markets not just confined to health services, but the larger global ethos of greater liberalization and privatization, actually brought in the process by which capital started becoming dominant and redefined and restructured the public sector and the non-profit sector. And I think that was extremely important and significant, because we saw a lot of that through the HIV/AIDS, where there was, in a sense, commercial interests and the role of global agencies like the World Bank funding and spawning NGOs to do work. So, there was, and I remember I was in VHAI at that time. I was working with Meera Shiva, and we could actually see how many priorities were being recast because of the patterns of funding. So I think this concept of commercialization as a theoretical concept was very, very important. And the way I see it is that we saw that happening in the Indian public sector. We saw it through disease control programs in big ways, especially with the way in which governance structures were changed. And so there was a lot of effort to bypass, if you like, public sector in the name of saying that public sector had large amounts of misgovernance, and how markets would be the corrective way forward. So I think that bit, having said and done, I mean, since I was working with Meera Shiva, there was this whole history of, the baby food case, then the depot. There are so many campaigns that were led by civil society organizations that were actually questioning and resisting commercial interests. And it was very interesting that a lot of these happened with networking from the South. So you had very, very interesting examples of networks of Southern civil society organizations being able to influence global agencies at that point, whether it was the WHO or the UN agencies. And you built resistances of certain kind with, I think, some very good policy impacts. But you see, this checkmating didn't stay on for too long as corporate power sort of consolidated in the way it did. And therefore, you had the tobacco story, you had the alcohol, you had, this food processing, which of course has taken on a very different dimension. And therefore, you found the consolidation of commercialization, moving from medical care, health service systems, to beyond that, influencing people's choices, behaviors in particular ways, which where the market played a much important role. And the last thing I want to say, I think I've run out of time, is to look at the way social media and the marketing through social media has become a very powerful tool, especially for health, and how it influences and sort of mesmerizes and seduces populations to make certain choices, which from a public health perspective, you'd certainly say are unhealthy choices. But then the solution to a lot of non-communicable diseases communications is that you are responsible for this and you have to resist this. But nobody is really examining the power of corporations in the way in which you do it. I just want to end by saying when we were students, we used to read Susan George's How the Other Half Dies. And I think it's a book that's probably forgotten now. But she was one of the earliest to sort of flag the commercial determinants of health in that very succinct way. I'll stop here, and I'm happy to come back later.
Thank you very much for that candid sort of reflection. I'm sure many like me would have seen how for us the health sector and also the world around us changed since 1990s, and you gave a very wonderful picture. You also highlight how social and commercial cannot be separated and how it needs to be studied together. And thank you for also highlighting some of the sources and books. I think this is very useful for our participants to refer back to. So we'll come back to you, and let me move then to Pradeep Narayan. He's a good friend and a guide for me to get introduced to the world of business and human rights. For the audience, just a brief intro that Pradeep Narayan currently serves as a director at the Partners in Change. He advises Praxis, but also has been advising many other civil society organizations. He has been teaching at NALSAR, which is National Academy of Legal Studies and Research, one of the very prominent legal school, but also at Indian Institute of Corporate Affairs. And I think in various ways, while Pradeep, you had really sort of long journey on development work, but I have seen that constantly your emphasis has been on social equity, on democratizing power and participation across development issues of communities. And I think in many ways, I see that you are leading the whole discourse around responsible businesses, both globally and in India. In various ways, I have seen you supporting but also learning from individual human rights defenders, from workers' movements, and also you are engaging very actively in shaping and making sense of both the global and national level discourse on United Nations guiding principles on business and human rights, which I think in India translates into different ways, like national guidelines on responsible conduct of businesses, or businesses being mandated to make disclosures on non-financial aspects, etc., etc. So I think this I find very interesting because I mean your journey also started with physics, if I understand. You did your degree in physics and then you go and do your master's in business administration. But then after some years, you also did your MSc in development studies from London School, the SOAS, London University. And I think from there, I have followed your journey. So maybe, yeah, it would be very interesting to rather listen from you in terms of how you encountered health and health issues. And if you can also tell us a bit about whether you see any promise within this discourse around UNGP or business and human rights world, if I call it like that, on whether we can address health impacts of corporations through that. Over to you.
Thank you, Upendra, for this opportunity, and thank you, Fran and Rama, for such a nice previous presentation. It was wonderful. Just reflect on what all were happening in the past and today. And I think somewhat similar journey which we had sometime, I think while we are talking about 90s, but something, post tsunami, what we saw was also about, since 2005 onwards, there was a global journey on what started becoming as a business and human rights domain. And I think we were part of something called Social Equity Watch, which Praxis was a secretariat at that time. And the purpose of the Social Equity Watch was to look at how many of the World Bank projects, how they create certain inequities in various domains, etc. So we were planning to do some studies, and some of them were also about mapping infrastructures in villages, how geographically they are located, how or away, including the health infrastructure. I think somewhere later we realized that sometime in 2011-12 we realized that the journey of human rights is not necessarily just with the state; it is with the corporates. So that is, I would say, the businesses had, by the time already privatization has happened, a lot of things have already moved into the private sector, and somewhere we felt. So at that time, I think the Social Equity Watch almost like rechristened itself as Corporate Responsibility Watch, and we started. And that was the time when the CSR in India, corporate social responsibility, was something taking shape, with 2% law coming into existence, where after profit 2% the businesses had to invest on corporate social responsibility, and it was shown as something remarkable for the country. But somewhere as Corporate Responsibility Watch, most of us were interested on how businesses are making profits rather than how after profits they are spending the money. So to that extent, what was interesting, something was happening at that time was national voluntary guidelines on business responsibility, including environment and economic. And these were completely voluntary guidelines. But in 2012, SEBI made this as a listing requirement. So while the guidelines are voluntary, the disclosures became mandatory. So in that sense, there was an interesting thing which was happening at the time of while corporate social responsibility was defined more as started becoming more defined as corporate philanthropy. And what we were trying to reclaim was what is corporate social responsibility in terms of businesses doing operations responsibly. So this was something which we got something hand in glove, and it was also the same time when we saw the data, public data getting less and less available on businesses, on workers, and many other constituencies related to businesses. You would see the things changing rapidly. And then you saw also the World Bank's Ease of Doing Business Index was something capturing the imagination of many governments in various global south. And many labor laws got diluted because of making the businesses doing business easy. So those were the times when we saw that a lot of things which were happening was most of the health advocates also were losing out on the information. What are the things which we can advocate, etc. While these are the issues as an organization, as a thing, we were continuously working on occupation safety and health issues, and also the accessing health interface for nomadic and semi-nomadic communities, and we are gaining experience over there. And also during the pandemic, we facilitated vaccination for in almost like 800 hamlets, and where all these things are the knowledge which we were getting from the ground, which we thought has to be linked with the macro things which are happening. Yesterday, for this meeting, I asked my team members, Dheeraj and Saisha, to get me some data on what we analyze around 1,000 companies of or their sustainability reports in India. And of the 1,000, around 82 of them are top 8. These are top 1,000 companies in terms of market capitalization. So 82 of them are from either pharmaceutical and biotechnology or healthcare services, healthcare equipments and services, some of these which are related to health. And if you see this, 80% of these companies have footprints in more than one country. And one company, in fact, has a presence in around 151 countries. 40% of their 82 companies' cumulative turnover is exported. 2 companies, in fact, export almost 100% of their products. So the terms of trade have a very important influence on the way the health priorities get decided. So in that sense, it is an important thing. And together, these companies employ about 750,000 people in their own workspace, which is 6% of what 1,000 companies actually employ. And 22% of their workforce is female. So in a way, we can say that the labor laws have a significant influence on the health. Of these 82 companies, only one company has reported being penalized for non-compliance with a law related to pollution. But 21 companies have revealed penalties related to issues like GST or confiscation of imported goods. And healthcare industry has the highest number of voluntary product recalls. And so in that sense, what we felt was this is something which has a important, these are some of the information which are available in public domain on the companies. And many of us may not know that for more than 1 decade, a number of health sector companies have been reporting on this information. These reports are rarely read by anyone, and less the reading, lower the quality. However, what we saw also was that things are changing very rapidly in the last 2 years. There is a growing number of what we call them as ESG investors, and nationally as well as globally. And energy transition targets are chasing the brands, suppliers, and MSMEs. So the ESG field is becoming more concrete and moving from voluntary to almost like a mandatory disclosure, and that too in public domain. And the companies are now recruiting ESG consultants to read these reports, etc. So in that sense, a lot of things are getting into this field. And terms like double materiality, the businesses are creating modules, how to do double materiality, etc. So I feel these are the times when health rights advocates need to enter these domains to influence these processes. Because if we ignore this, whether we do good or not, there might be more barriers for us to fight, right? So it is important for us to get into these domains to at least reduce the barriers later on. For example, health is often related to the product use. Human rights due diligence debates which are happening are largely talking about how the products are created, less about how products can cause harm. So if we ignore this, there will be less of these kind of information flowing into the thing. Further, the health, in fact, especially of occupational diseases, is seen low in the priority. So they talk about, because the impact of the diseases will be seen in the workers much later. So those are the areas, again, not get discussed much. Similarly, drug testing practices of the companies and how to protect communities from becoming victims. These are some of the areas which can be brought under Human Rights Principle 5 within those debates. Similarly, the export of hospital and medical waste globally, especially hazardous ones to poorer countries, are rarely discussed. So I think in this domain, where what you just asked on the UN guiding principles and business, this domain is something literally expanding, because this can work within the capitalism, right? So So people don't have to challenge capitalism. So until the system works in such a way, they allow the freedom till you don't challenge the isms into it. But this is the time we might have to take leverage of this. And lastly, for example, the need is also to ground these debates locally. It is not just about big corporates. The value chain extends to petty contractors and local vendors. For instance, in one of our programs in Dindugal, we found a block medical officer actually told us about increasing incidences of teenage pregnancy deaths in one district. We worked with small businesses around child marriage. We worked with the marriage hall owners, flower vendors, caterers, to talk about teenage pregnancy and child marriage as a pledge, as a thing, as a sensitizing issues. Similarly, an increase in drug addiction among youth requires us to build sensitivity among local pharmacies over there to identify products that could be used by young children in their practice of drug addiction. So I would say this is a domain where not only the macro picture can be addressed, but also somewhere the micro level interventions around health is also something which we can engage with in this domain. And this is a very young domain. A lot of things are being discussed at a stage, and this is the time probably a lot of people who are original health rights activists to get in and speak with this young people of ESG consultants, ESG experts, etc., and build the knowledge around it. Yeah. Thank you.
Thank you so much, Pradeep. I think we hear your very emphatic call that public health folks must engage in this, growing debate around business and human rights. I think you beautifully connect the micro and the macro, and I think that example is wonderful. Also, I think you give a sense that indeed there is a promise. While there are pitfalls and there are areas of caution. But it's the time for us to engage and optimize, and possibly another avenue that public health folks have not really engaged much. And I appreciate you again pointing out to kind of data which is already available for a while. And I think some of the colleagues from Partners in Change have posted links in the chat box where you can also see how this data is easily available and can be utilized to look at the sector. So thank you very much, Pradeep. Hopefully we'll again engage. I'll now move to Dr. Ravi Narayan. He has been a mentor to me, but to many more like me who have been on the path of public health and community health in India. So Ravi, I mean, for those who don't know him, is a medical doctor and worked at a medical school for a while, St. John's Medical College here in Bangalore, before he started his journey really into community health. Founded an organization in 80s called Sochara, the Society for Community Health Awareness, Research and Action. And for last 4 decades has been playing different kinds of roles. And now I think he calls himself as philosopher in residence, archivist, and storyteller. Thank you for being that for us. And I think, Ravi, when I see your long illustrious journey, of course, you have engaged with healthcare reforms, both nationally and globally, trying to make them people-centric. But when I look at your contributions over time, there are two things that stand apart very clearly. One is that you always advocated for and nurtured the whole community health paradigm, definitely in India, but also the whole global movement around it. And you also made many of us see and believe in health as a social movement. You have been part of various movements, and particularly you have been very active member of People's Health Movement. You managed national chapter for a while. You were part of the global secretariat, and you continue to be a member of the advisory council of the People's Health Movement. You often refer to community representatives, community-based organizations, and social movements for health as constituting some sort of countervailing force, which is very much needed to achieve health for all. It would be very interesting to hear from you. I think the only medical doctor in terms of journey today, to hear from you how one would look at the way we are discussing commercial determinants of health from a lens of community health. What role in past, in history, communities and social movements have played in addressing the health impacts of corporations, of businesses. Over to you, Ravi.
Okay. Thank you, Upen. It's a great pleasure to always come back to IPH, so full of Sochara colleagues and new friends, and even more of a pleasure to be in a panel with two old friends, Fran and Rama, with whom, especially since we started Sochara and later PHM, have been so closely working together in so many different ways. I think it was really nice for me to listen to Fran and Rama and Pradeep, because it set the stage for what I would like to say. Initially, when I was a bit confused, because now, as Upen has said, being the philosopher in residence, you first start with what do these words mean? And I had to look through all the work that I had done myself or read of other people, Professor Banerjee, Dr. Jeffrey Rose from the epidemiologists, all of whom we regularly quote when we say, how did we start all this? Dr. Antya and so many people, I don't want to go into details. I felt that then I did one more thing just before I prepared for this session. I had a very nice discussion with Upendra initially, because I said, well, I have nothing to say much about commercial determinants of health, because I didn't even see commercial as a determinant of health. I mean, I'm so used to in Sochara looking at social, economic, political, cultural, ecological, and environmental determinants. And I see, yes, of course, money and business and profit are not as important, but it's part of social determinants in my mind, at least. And it's only after Open came and told me that I began to read, and I read the WHO. I straight away went to the WHO website and tried to see what they felt, and then slowly began to look around. Now, I was just thinking, what would I like to offer to this conversation? It's basically a conversation. It's not my view or my opinion on any of this, but it's to where are we, where have we come from, and where are we leading to? And I'm interested with having come from, France starts from history and comes to social determinants. I start from medicine and go to history. Because when you're an archivist, storyteller, you start with, I'm not telling stories of my own, I'm telling stories of histories of community struggle. And some of the words you've all used is very useful. So let me not, my journey itself as a doctor changed when I finished from medicine, St. John's Medical College. And I think over the first 10 years, which is the 10 years when I was an academic, it was part of this churning that took place as an academic and seeing reality. And I had 4 expressions of reality, and I always felt that our whole community health learning program in Sochara is based on either getting people from the field or sending them to the field to understand reality. Because I believe, we should, though we are called Society for Awareness, Research and Action, it's action reflection. You act and you reflect on it. So it's like learning. One was the refugee camps. When I was a young intern, suddenly went to East Pakistan refugee camps and worked for 3 months. My life completely changed. I found hospital medicine taught you nothing to handle health in a refugee camp. I came back. The only department I could join was public health department, and I went to London. I studied London School of Hygiene, did public health industry. When I came back, I did 2 things. One was we set up India's first health cooperative. It's known, and therefore some of us are known as pre-Alma Ata pioneers, because the 14 projects that happened in India before 1978, including Jump Kit was the most famous one, but there are 14 of us who had experimented with health in the village. And I found that the health, when you look at health from the villagers' point of view, from a health cooperative point of view, and I won't go into details of that. So Malur refugee camp, my work with the London School was an overseas link to look at plantations and how plantations could begin to see as healthcare. This was pre-Alma Ata, but again, after Alma Ata, it became stronger. And finally, since I trained in industrial health, I came back, but I decided I won't look at industry, I'd look at agriculture. Now, all these 4 took me outside of the medical college hospital. That's what I want to say primarily. And I began to see in all of them, I was working with people. I was working with refugees. I was working with the village cooperative leadership, the dairy cooperative. I was working with, plantation medical officers or plantation workers, and I was working with the.
For everyone, he is giving this. This is extra one, no? Na bag lo pettu.
Somebody, anyway.
Yeah, you go ahead, Ravi. Yeah, we will manage to mute the participant.
Dr. Ravi, you're on mute.
Yeah, if we can, Ravi, you're on mute.
It's not.
Go ahead, Ravi.
I would say that I always began to find that my understanding of what was going on and what needs to be done was always during these 10 years modified by the fact that when you talk to the community who was experiencing what you were trying to deal with, it was very different. And so this whole idea that health and well-being of communities is very different from the ill-being mentality that we doctors have. We say health is physical, mental, social, but we actually land up doing ill-being, disease. And so a group of us, and it was not only me, we were a whole group in Sochar, St. John's, who were all having these sort of experiences. And we therefore moved out to start exploring community health. Today we are called the first startup in community health. We didn't know what community health was, but we knew what it was not. And it wasn't hospital medicine. And so it was a long journey. And I'm not saying my journey, but what is very important was everybody we met, everybody we talked to since 1984, we always brought in the community and said, do we understand whatever you're saying from a community perspective? So I would say at the end of it, a commercial was then becoming very obvious to us, because at every point of time, the government services, as Rama herself found out, was not adequate. I remember having heated discussions with Professor Banerjee, who was very fond of us and was wanting us to quit and come and join JNU, that we can't keep sticking to the government. But half the experience of the community, 3/4 is outside of government. And everybody from traditional healers to dais, all the way up to corporate, they are negotiating. So therefore, there was something we had to do, and all we could do was start looking for such, information. And I must say, Sochara, because we were not considering ourselves an academic, we were considering ourselves as a praxis-oriented group, we kept looking around for people. So everybody, including 2 people on this panel, are friends, because we could rely on them and their data, and we knew their data was somehow relating to this community reality. So coming to it, what I would say is that the point I would like to say is, the reason why you have asked me to join, even when I was hesitating, was because I think the community perspective, if it comes in, that would be like the end of the story sort of conclusion, is very important, rather than we getting into these debates about capitalism versus socialism, public versus private. Because what does it mean to people? I am very much deeply involved in all those debates also. And I find that when you start talking about communitization, and so I feel very strongly about that word. I'll give you one example, because when I don't know how many of you know that when we brought 18 national networks together in 2000, before, as a preparation to go to People's Health Assembly, we got 18 organizations together. And I always tell people who come to Sochara, if you want to understand who all can contribute to health, please read that list. 18 national organizations, of which only 6 were medical or health. There were the trade unions, there was the women's movement, there was the environment movement. So I think that's very important. And all of them gave us perspectives of the community. Another important point is, when we started the movement, the National Rural Health Mission came up. And when the NRHM came up, I'm always surprised that 25 of us in India from the People's Health Movement, Jan Swasthya Abhiyan, were invited as consultants. Not a single, professor of community medicine. And we were in all sorts of action, from, public health, standards to everything. So slowly the government also, and everybody is beginning to feel, yes, we know the corporate view, we know the government view, but we don't know what the people want. And I think this is a very important part. it also comes to then research. So our role has been just as a galvanizing role to make sure that in every debate, the community also begins to participate in its own way, whether it's action research, now we have all sorts of methods of that. I just want to quickly tell you two, and then we can go back to the debate. Just to give you an example, I discovered that the only way we could bring the community was to do something together. So I just give you two examples, one abroad, one foreign, and one global and one national. I remember talking to other, you could call us, you could say scholar activists we had become. Whereas some of you might have been what we call activist professionals. We're all dealing with the real world, but we're looking at it from a different point. I remember having a long chat with Amit Sen Gupta. Amit and I worked very closely. And when the government of India wrote the National Health Policy of 2001, we had a big meeting. We discussed it all. And then we said, we know what the critiques are. But what we did then was very interesting. On behalf of the People's Health Movement, we produced a small book, which was the government of India put its whole policy up on the web. We kept that policy, but we used internet technology to sort of cut lines across certain sentences and put in our sentences. Till today, this book is often used in places when you want to, and we called it legitimizing privatization. Learning from all the people we knew, including Fran or Rama or Dr. Banerjee or anybody else, we began to find that all those trends are being brought in very subtly into government, couched in primary healthcare, couched in other languages, but always concessions for the private sector for increasing privatization. And just before that, we had produced a book called Confronting Commercialization of Healthcare. And we used the word commercialization. It's the fifth book in 14 different languages in a cartoon approach. We're dealing with what commercialization is all about. So what I felt was that what we have tried to do is, as we continue these debates and as we continue to move towards action and even try out, we have to keep doing that. Now, one quick short one for global. When I was part of the PHM, there again, here you have the I-18, there you have G8, 8 organizations. Many of them have been referred to by Rama and others, the international people, the IOCU and IPFAN and all these groups. We brought all of them, Third World Network, all of these people together. In WHO, Zafrullah Chaudhary and I, who are considered like 2 or 3 scholar activists of the movement, decided that WHO must have an advocacy circle. So the first thing PHM did in terms of global was to form a small advocacy circle. And we used very creative methods, which I won't tell you about now, but there are stories written on how we went into every World Health Assembly and began to raise issues among, and today it has become structured into the Global Health Watch, a whole a book that is written once in 4 or 5 years, and the WHO Watch. And these are all methods by which community perspectives and perspectives from the real world are brought into the whole thing. And finally, I just like to end by saying in 2013, when the Health Promotion Conference in Helsinki decided and had heard about all this, had heard about all our work, not mine, but Fran, David, the whole work. There's so many of us from PHM who are making these sorts of issues. I was invited to that Helsinki conference to talk about the same question which Upendra just asked me: can we be a countervailing power? And I presented countervailing power, whatever stories we had, whatever we had done in our own way. And 2 very interesting things, and I'd like to end by that, saying, unfortunately, we haven't used it. If you look at the Helsinki Declaration on Health, every Fran knows from the time of Ottawa, they have met every few years and there have been new understanding. 2 things are introduced for the first time. First time, a WHO document in a declaration, of course, it changes when it comes into policy, says that civil society and social movements, they've used the word social movements for the first time in a UN document, should be invited always into the dialogue. And simultaneously, to back up, they say every time the private sector comes, conflicts of interest must be looked into. You won't find a document where this is so clearly said as yin and yang. You need the social movements, you need conflicts of interest. So I would like to end here by saying all these are documents that are available, and I would like younger researchers and people who are dealing with this problem to get involved with this. The less said about World Bank, then that itself is a whole webinar on its own.
Yes.
Critique of the World Bank, which we've all been participating in, starting from the first People's Health Assembly. Okay, thank you.
Thank you, Ravi. I wish we had more time to listen to more stories like this. Unfortunately, today we are running short on time. So thank you for at least giving that very broad picture of how, and I think you covered some of the comments we received from the participants on what it means for an ordinary person, how the ordinary person would think about these forces, to how some of these social movements and community action appeared in more formal discourse. So I realized that while we have crossed the time we had fixed for the first round, I also wish that just like me, most of the participants would have found this very, very useful, because it's not just about discussing the technicalities of commercial determinants of health, but also listening to your own professional and life journeys, to me is very, very crucial for many of the younger professionals who wants to work on these thematics. So instead of going for a whole second round of talk, given the paucity of time, what I suggest that I bring up only a couple of major questions that had come up, both part of the debate, but also some of the participants. And maybe if some of you want to engage, and maybe this time we can be brief in terms of how we try to address it, so that we can cover as many more questions as possible. Maybe I'll start with the reference to colonialism. I think Fran made a reference to colonialism itself should be considered as commercial determinants of health. And I think lately I see that, Pradeep, you have been involved in creating a series of documents or booklets where you folks talked about decolonizing the global debates on business sustainability, where you are talking about how it's not just about building solidarity among global south, which is needed, and I think Rama Baru also referred to global south in some sense in earlier of her intervention, but you are saying that we also need to challenge the global north, and that requires kind of different kind of epistemology. So and I think in global health we have parallel movements, so to say, around decolonizing global health. There is a discourse building around that. So I was wondering whether some of you have quick comments on how you see that, and if some of the things that you are doing work around it. So maybe Pradeep, you can start, and I would invite other panelists to chip in.
Yeah, of course, I think a lot of things. We started something called Global North Dominance Watch because most of the discourse on colonialism was on solidarity of Global South, and rarely people were watching on the Global North dominance per se. So we wanted the gaze to be on the Global North dominance and to identify what is happening there, to look at oppression rather than oppressed. So what is that? And literally it is about like, and the immediate trigger was what is called as mandatory human rights due diligence laws, which were coming out from the global north countries. And primarily the law actually mandates the MNCs, multinational corporations, to give information about what is happening in the value chain, which means global south. And in fact, we found it as a both human rights reductionism as well as value chain reductionism, not looking at trade, but rather looking at all the transaction between two entities. So with that as an idea, as a trigger, we started working. It is very difficult to unite the global south, but it is not difficult to define a global north dominance, because so therefore it was important to us to get into some of these debates. The second thing we thought was most of the epistemology which is being used is largely from the global north. So there is a good nexus between publishing industry, the academic industry, as well as the public universities is no longer public government funded. They are all looking for bidding for grants, etc. So literally most of the traditional autonomy which we say for public universities are no longer existing. So in that sense, it is, and public universities are getting money through what is called in Global North is through evaluations, and evaluations are part of the development aid. Otherwise, the ODA, overseas development, official development assistance, which is 7%, which any Global North company. So we felt that a lot of things are very much linked to the debates which are happening, and even the current, what Fran was speaking about, Trump and Musk. It is, while we are not necessarily, asking for, funds from thing, but ODA, official development, is just like any affirmative action thing. It is a right claimed by Global South for 3 decades from 1950s to 70s. So it is, we may not agree with the form of ODA, but what is important is the reparation is a right which we need to claim back. So in that sense, I think a lot of debates are something which we thought we should engage with, and bring those issues back into the picture, through which, and the last point I want to add is that even the Global South countries are trying to imitate the Global North. So in that sense, it is what Ambedkar said as imitation of, infection of imitation, which is like everyone is trying to become a Brahmin here. So in these scenarios, it would be, what is more important is to challenge some of the epistemology and bring back some of the concepts of Paulo Freire or Ambedkar or Karl Marx back into the domains of discussions. So, yeah, I'll stop here. Thank you.
Thank you. Thank you, Pradeep. I think in global health, we have a raging debate. Say Mbimbola and others are also talking about epistemic injustice in global health. Any quick comment anybody wants to add, Fran?
Just quickly say, I think, to build on what Pradeep said, at the moment, it's really odd because with the US aid crisis, it's so obvious that the conditionality of aid is totally in the hands of the global north. And of course, from the People's Health Movement, we've criticized US aid over many years for its colonial attitudes and its imperialist attitudes. But on the other hand, just withdrawing it is going to have devastating consequences around the world. So there's a real issue. And I guess what we have to recognize is in Australia, my Indigenous colleagues don't really talk about post-colonial, they talk about ongoing colonialism, because there's still all sorts of ways that happens. But we're now moving into a much more, the American kind of century was a unipolar world with their power since the Second World War. We're now moving into a much more multipolar world. The BRICS countries, I think, now are 35% of the global economy. So it's a different world. And I think, any analysis of sort of global health governance, we have to deal with that different world. And the latest moves by America actually is probably weakening their position globally anyway, in the long term, whatever it's doing locally. So I haven't really thought through all the implications of that, but we've certainly seen how how aid has been conditional on the global north, and that's just unacceptable, really, as a way of doing business. So, yeah.
Thanks, Fran. I'll bring Rama, but just wanted to say before that we have about 3 to 4 minutes left. I would not sort of enforce people to stay back, but if some of you are interested and if some of our panelists are available, we can maybe stay back for another 5 minutes or so to cover some of the questions. But those who can't, feel free to leave. So Rama, I know you have a comment on this.
A very, very quick comment, and I think it's of concern that there is a certain elite capture in the global south, which has completely partnered with the global north. And I think that is going to be a big issue. So while resistance is important, we need to acknowledge that our own leadership, some democratically elected and some not so democratically elected, there is an elite capture in the imagination of the political class, as there is in the business and the intellectual class.
Indeed. So I think we need to talk about democratizing power. Otherwise, you have this like ongoing colonialism, as Fran says. So maybe one more and probably the last probe I wanted to bring based on some of the questions we received is, I think Rama, you said about commercialization as little different than just privatization, because you then problematize commercialization of public sector and how it undermined public sector over time. While much of the discourse around commercial determinants of health today is all about private sector. In fact, the WHO definition or any definition I came across generally talked about private sector activities. So I'm wondering, your thoughts on this. Of course, while the concept itself use the word commercial, but somehow the gaze is only on the private sector.
No, I think it is giving, it's about power relations, right? And so it is just saying that markets have been very powerful in the way they have reshaped. And I want to say not just the public sector, but also the NGO sector and communities. So, to me, the role of markets is not just about changing structures, but it is about how people think, how institutions have been reconfigured, and how people's choices have been redefined. So I think somewhere that's why I feel commercialization is a much more powerful concept. It's much more complicated, and it requires a great deal more teasing out. But I think it's worthwhile working with that concept.
Right. Wonderful. So we had received few questions, and I'm worrying that we may not be able to cover everything. So I'm trying to prioritize. I think there is a question by Dr. Amit Yadav from Vital Strategies. He says that what legislative and policy approaches are available or advisable for India to address commercial determinants of health, especially to mitigate conflict of interest for preventing influence from commercial and vested interest. How to censor commercial communications from influencing health behavior. So basically, how to really protect public policy making, from the conflict of interest. So if some of you want to highlight some of the measures that either you have come across or you would like to recommend. Yes, Ravi, you want to come in?
I just want to flag that a very important point is that many of these remain debates because we haven't collected enough evidence. And I think evidence gatherers who are listening in to us must begin to see, just as Rama has mentioned, to me, a lot of what she did, for example, when she was looking at corruption in medical education, she came and met us, but she was doing it with a student who was doing a PhD. I think we need researchers to look at this because very often we are taking positions which are still one-sided, because from the corporate side you have enough evidence. At least we don't think it's evidence, but they say it's evidence, and from our side we have an opinion. And I think we need to collect data on each of these issues. And I just want to come back to one important point, which again is something that needs to be researched. We are talking about markets. There's a lot of work going on in markets, but not enough work on elitism and elite capture. And I often hesitate to say South versus North, because elite of the South are just like the North. In fact, the North is more open than the elite of the South, and especially in the medical profession, which beats the traditional caste system of India hollow. I mean, the caste system of medicine is so strong that it is very difficult to talk about communitization to a doctor, because a doctor is threatened even by the nurse or by the nursing aide. I mean, forget about the community. So my feeling is, while we're studying markets and doing things about market, we must looking at, I won't say caste, but elitism, or what you call discrimination, all sorts of words that will come to between people.
Sure.
Within those who are trying to solve or trying supposedly to try and move towards that. And I think that's very important.
Sure. Thanks for pointing out that there is a lot of things to be researched. Coming back to that question of any measures you would like to recommend around preventing conflict of interest.
Well, I mean, just to say it's quite hard to do, but I mean, the way that people do it are having guidelines or rules about conflicts of interest that you have to declare them, and I think the public sector's been much better at getting people to declare conflicts of interest. But then the issue is, even if you have some rules, how do you monitor it? And I guess anti-corruption commissions are the way to do that. And there is a whole area of research on corruption and conflict of interest that I think there is a lot of evidence there, Ravi, actually, on that. And I guess it's about public health looking. I work with a colleague, Adam Graycar, who's done lots of research in this area, and he does it globally. And there is a lot of evidence on how you can have, governance of conflicts of interest. And I guess, it's having a government that's determined to do that and implement it. And how you do that in the corporate sector, I think there's also, quite a literature on that. We've had some terrible examples in Australia. We had a Senate Select Committee looking at the behaviour of the consultancy companies, and PwC was found to be advising our tax office on the rules for corporate taxation crackdowns, at the same time giving that information to their private clients of how to avoid it. So that's become a public issue in Australia, where clearly their conflict of interest was massive. So they're not getting many government contracts now, and their head of their Asia business had to resign. So a government inquiry unearthed that. So that was one way of governing the conflict of interest, where they found this very direct conflict of interest. So you can use, parliamentary procedures, having strict guidelines, and then having independent commissions against corruption, ICACs. So there are lots of ways, and probably public health should be looking very closely at what all those mechanisms are.
Sure. Thank you. Thank you for highlighting some of the modalities that have been used. And I think some of these issues, be it decolonization, democratizing power, conflict of interest, I guess we can do a whole episodes on some of these issues in this series, because we are not going to end with today's episode. But unfortunately, because we have run out of time, it's already 5 minutes past our scheduled closing time. So maybe I'll now close this here thank you very much to all the panelists. I think I'll not even attempt to summarize anything here. It's just difficult, but I think you all did wonderful job of really highlighting all complexities of commercial determinants of health. That why it may look like a new catchy word, but a lot of it is not new, and how one needs to really engage with complexity. And I think your own professional and life journey provides very good relatable examples for many of us who wants to go down this path. So thank you very much. We have recorded this, so we will edit and disseminate the recording of this, and we look forward to having you again in the future episodes of webinars under this series called Conversations on Commercial Determinants of Health.